Section 7. Hope you all are doing well. This is the replacement wrap up for the one that I did yesterday, where apparently I did not have the volume turned on. I think it's in the new OS for Mac. It self defaults to no recording, and I didn't realize that, and so I hadn't used the screen time. I hadn't used the quick screen grab for recording I did yesterday, and it was to my mistake. So I'm back to using QuickTime. Anyways, enough of that. So here we go. Weekend. Here's the Block 3 wrap up. So overall, I thought we did really well. I was really pleased with the discussion. I was really pleased with people bringing extra literature. Man, I really was like, wow, we're getting it. People are starting to understand it. And they were gearing their conversations around the literature. They were talking about their clinical practice as it pertains to the literature, whether they were doing it before, whether they're going to start doing it now. That is what I'm looking for. That is the kind of dialogue as we reflect on the literature, as we reflect on our clinical practice, and then we decide, are we going to change? Are we going to stay the same? How are we going to adjust based on do we have enough information to move forward? So I really, really enjoyed that. So starting with the Coombs article that one size does not fit all. Great article talking about how lateral epicondylalgia is not just about tendinopathy, but it's really about a variety of different things that could be causing the pain, and that treating it, we have a couple of different options, and depending on where the person is, if we stage them based on irritability, that we can use to fit them. The clinical examination, right, how important that subjective exam is. We know that there's a couple people who posted articles in regards to the in regards to some of these psychosocial or yellow flags that can make somebody more irritable. We know that what the physical outcomes can be. We're using our sins to help guide us, mostly, again, using irritability, although even in this case, right, nature becomes a really big deal. Is it nociceptive? Is it peripheral, right? Is it nerve involvement? Differential diagnosis, understanding what is at play. So this next slide just really goes over, from the Coombs article, the kind of differential diagnosis of possible problems. And so at any time you're looking at anybody when they come in and you're thinking to yourself, is this just back pain? Is this just shoulder pain? Are you running through your mind, what are the other potential offending structures, especially when it doesn't make sense, right? It needs to make sense. And that's the value of having these things at your disposal, so that understanding that, okay, I've got to check this, and this, and nope. Yep, it pretty much is what I think it is, or it's not what I think it is. From the Coombs article, now this wasn't talked about a ton, so I thought I'd bring it up. Understanding that imaging is not helpful. Understanding that we can pick up a lot of, we may be more sensitive, but less specific. We have a 50% unaffected for both, basically 50% for both the ultrasound and the MRI. So we're picking up things that aren't helpful. But I do think, and this goes back to, some people were a little bit put off by just the wait and see approach. And I would argue that the wait and see approach is often filled with education, and patients totally feel better when they understand that they're not causing damage. And in a lot of cases, we're just guiding them through this process and letting them know that, that you're not going to cause damage. And very possibly it could calm down. And you may, if you're an exerciser, want to think about exercising in this way, understanding that your avoidance of, maybe they're doing shoulder lateral raises because it hurts. That's probably going to be helpful. Pain, and then understanding what pain represents and how that can guide them, right? So that wait and see approach can be just education about how to move forward. And there's absolutely nothing wrong with that. And very powerful. Based on the Coombs article, we know that the corticosteroids offers a much short-term relief. We still obviously want to take in the sins. We want to take in, the wait and see approach, which is relative rest and activity is tolerated. Manual therapy, you've learned some things at your weekend intensive, but we also know that, so we have lots of things based on what you learned at your weekend intensive at our disposal. What do we have? We have mobilizations with movement. We have soft tissue mobilization. We have dry needling. We have mobilizations of the radial head. We have cervical glides with or without upper limb tension bias or neurodynamic bias. We could just provide high velocity thrust to cervical and CT junction, which was done. We could manipulate, I shared with some people, the wrist, HVLA to the wrist. But if you look at the article that I shared with a few people, they did it a ton of times. And so it didn't seem really practical. But again, it's about putting in an analgesic effect into the nervous system to help increase mobility and decrease fear. Exercise, lots of things, sensory motor, controlled appropriate loading. I mean, this seems to be the go-to, right? Isometrics, some people talked about isometrics, for isometrics related to tendinopathy, the real article that I think Trent posted, I think I may have posted once, even though it's for patellar tendinopathy, it was looking at like 45 seconds, 3 times, these prolonged holds, concentric or eccentric. I don't really think it matters. I think if you're progressively loading and you're doing it in a kind of, I would argue that much like BFR, blood flow restricted training, for those of you who are using that, in BFR they use a metronome to count out a pace, if you will. And I think the pacing is important and kind of this slow progressive loading, just so that they're not moving quickly through it, that they are doing a full arc of movement, that they are slowly lowering it and slowly moving both into the concentric and eccentric contraction. I don't know if it's just about eccentrics, but perhaps just the progressive load in a paced fashion. Regional interdependence. There's a couple of people cited some articles that talked about scapular weakness as it relates to elbow pain, and I certainly have found that to be very true. I oftentimes start my patients off with a shoulder abduction exercise with TheraBand, where they go up to 90 degrees in shoulder abduction. They get a shoulder workout, and they get a nice shoulder strengthening exercise, and they get some isometrics into that ECRB. Something to think about, but I'm totally into that. I mean, obviously, much like the knee, we strengthen the hip, and the knee seems to respond pretty well. And then just functional training. And then education, right? We talked about, and from an education standpoint, it's basically what is tendinopathy. And I shared with some people the Cook-Purdom article from 2009, and Trent also posted the diagram of the slide that they use, and I think that article is a seminal article. It just nails tendinopathy, and there'll be some nuances to that. Obviously, that article since 2009, but it really kind of hits home at what tendon pain really is, how you move through it, how it comes on, whether it's reactive or degenerative, the concepts of treat the donut, not the hole kind of ideas. These are all things that they do a really good job of. So if you haven't read that article and you want it, I can send it to you, or if you can get it on your own, I would go get it. It's in BMJ. Okay, now Coptiers. So neurodynamics. Consider irritability. So less about acute and chronic, more about irritability. My goal is to try to put as much tension into the nervous system as I possibly can to try to get the greatest excursion. That may happen. To start with, it may just be nice and easy sliders just because they can't tolerate anything, and I just want gentle movement. And if it's, if they get if they have a lot of involvement at the elbow, whether that's radial or medial nerve, or median nerve, I might just have them move their elbow and wrist in and out, right? Just like a slider would do. If it's more than that, we put in greater tensions. There was some brief discussion about, in a really acute patient, would you see positive upper limb, or would you see positive neurodynamics in the lower extremity? And I will definitely say yes, I have seen that. Now, it doesn't happen very often, and it's usually with somebody who's extremely acute, has a lot of yellow flags, and they're just basically their cup is completely full and overflowing. But I have totally seen a positive straight leg raise at, like 65 degrees that radiates up into their shoulder and their arm. So it happens. And it could be a great place to start if you are looking for somebody who's too acute. They don't want you to touch their arm. Everything just hurts too much. You start moving from a neurodynamic standpoint, lower half, or just simply sit slump, right? Without any, that could be a really good exercise or opportunity for them to move and to mobilize the nervous system. So again, the forum posts were very solid. I really enjoyed reading a lot of them. Remember, if you don't have experience, what does the literature say? Comment on the literature. I realize that more and more of us aren't seeing elbows and wrists, and that's a problem, I think. And because I don't know if everybody else is following load progression. So, and understanding that you can treat the elbow through the neck, right? Again, if you don't have experience, follow the literature. We're going to be moving into the next one with sports. If you don't have experience with sports, what does the literature say? The patient case, it was all pretty straightforward, right? That was a pretty straightforward case. I would have liked it to have been a little bit more complicated. Even the patient was wondering, like, when are we going to get on with this? Like, it's just my elbow. Even though the person doing the eval was doing a very thorough eval, making sure he had checked all the boxes and made sure that there was nothing else that could possibly be going on. I was just, and you all nailed it, right? It's grip strength. It's you can certainly use a numeric rating pain scale. We have functional asterisks, like the gentleman talking about lifting up his briefcase. And if you can't come up with one, a good PSFS would be perfectly appropriate if you don't have a good elbow outcome tool. So that was, and everybody seemed to be completely on board with that. So next block, upper quarter exercises and sporting injuries. So block 4, patient case intervention, reach out with questions. So we're going to get to the treatment. Obviously, we've talked a lot about the treatment in block 3, so that shouldn't be too big of a deal. Don't forget to do the end of course survey as we finish up this last and final block. I have Alpha, Bravo, and Charlie. Trent has Delta. I will tell you that I'm probably going to be a little bit delayed in getting to block 4 posts because I'll be traveling Sunday afternoon and evening. And so I probably won't be able to, if I get to a couple on Sunday, it'll only be a couple, and most of it will be done on Monday and Tuesday evenings. And then I'm also teaching at the University of Minnesota. I have 3 lectures that week, and so it's a busy week. So just bear with me as I try to plow through it. Everything, it never fails. Everything seems to happen all at once. But I hope you guys enjoy the rest of your weekend. And again, my apologies for having to do this a second time.